A very warm welcome, Croeso cynnes I chi gyd, to our annual lecture. We are Global Health Partnerships Cymru, and my name is Dr. Julia Terry. It's my great pleasure to warmly welcome you to this event today. And I'm just going to start by doing some housekeeping. This session is till 3 p.m. British time, and we will have a hard stop there. And we will be hearing later from our inspiring speakers. We'll hear a little bit more about that in just a moment. So I want to take this opportunity to let you know that we have a new name. We are Global Health Partnerships Cymru. Previously, we were the Wales and Africa Health Links Network, and our mission is all about working in partnership with our health partner links, where we have a charity in Wales that connects with a partner in an African country, usually an NGO, and we are very much all about engaging and supporting with our partner links and stakeholders and thinking about providing mentoring, guidance, education opportunities like this, working particularly with diaspora organisations and staff, and thinking about how we also have those important conversations with health boards, governments, stakeholders in the global space to improve global health. So we are a new name, but the same mission. And we are going to be using this opportunity for our annual lecture to hear from some expert speakers on the topic of antimicrobial stewardship. We would encourage you to please use the Q&A box, which you'll see in your Zoom bar at the bottom of your screen. So Q&A, you'll see the little speech box with a question mark. Please do feel free to use that, post your questions or comments in there, and we'll keep an eye on that box. And we'll be managing the questions towards the end of the session. So just as a reminder, this is being recorded and will be made available to people in the coming weeks, and please do pass this round to your colleagues. So it's my great pleasure to thank, on behalf of Global Health Partnerships Cymru, to thank all our colleagues at Hub Cymru Africa who make this possible, to thank our Welsh Government funders for their ongoing interest and support. And I'd like to hand over to Professor Tony Jewell, who has agreed to host our annual lecture this year. Tony.
Thank you very much, Julia. Good afternoon, everyone, and welcome to this year's annual lecture. This is actually the 7th in the series, which we've covered most of the most important global health priorities, including global inequality, the climate emergency, the effect of war on health, as well as more specific things like maternal and child health, as well as, working last year with decolonizing healthcare solutions from Matthew Harris. So we've covered a large number of areas. And this year, we've decided to cover one of the top 10 global health priorities, namely antimicrobial resistance and the projects across the world in terms of encouraging antimicrobial stewardship. Infections to antibiotics is the focus. The UN Assembly met in September this year and flagged it as a global emergency. It is in the top 10 of the WHO priorities, global health priorities. And in the UK, it's actually on the National Risk Register too, alongside flu and other pandemic causes. So I'm delighted that we've put together a program this afternoon with 3 parts. First part, an introduction on AMR, AMS by Victoria Rutter, followed by 2 videos, one from a colleague of Victoria's who is based in Uganda to talk about sub-Saharan African projects in AMR, AMS that she's been linking with and working with, and to finish off with a short video about the Malawi-Wales partnership. These are all 3 will be just part of this evening's or this afternoon's annual lecture. And we've got about an hour, and there's a hard stop at 3 o'clock. So it's just a warning that we'll get through the business and allow time for Q&A after the speakers and videos. So let me just quickly introduce Victoria, who's a pharmacist and Chief Exec of the Commonwealth Pharmacists Association in the UK. Victoria became the first Executive Director of the Commonwealth Pharmacists Association in April 2016. She's built a very strong team, redefined the charity's mission, and led the organisation from strength to strength, including the Commonwealth Partnerships in Antimicrobial Stewardship programme, which is something that these programs we'll be talking about this afternoon relate to. And I've certainly been involved in one in Kenya. And it's really excellent work done by this organisation to pull together Commonwealth countries as well as the UK in trying to tackle this global emergency. So without further ado, I'd like to welcome Victoria and thank her very much for joining us this afternoon. So over to you, Victoria.
Thank you, Tony, and thank you, Julia, for the introductory remarks. It's really good to be with you all today. I can see some familiar names on the line. It's really nice to have you join us, as well as some people that probably don't know much about our work as well. I'm just going to attempt to share my screen, so just bear with me for 1 second. Hopefully you can all see that. Could anybody just let me know if they can't?
It's fine, thank you.
Thank you. Right, so as Tony said, there's 3 parts to this lecture. I'm going to talk to you about an introduction to AMR. I think Tony's done a really good introduction himself, actually. I may not be needed. And then we're going to hand over to my colleague, Max, who's going to talk about some of our AMR programs in Africa. And I can see some of our health partnership here from Wales and Malawi. So I can see William and Kerry on the course. It's nice to have you with us. I know you've got a video to kind of round this all off. So let's get started. So I'm going to talk to you a bit today about these things on the screen. So we'll explore who we are, the Commonwealth Pharmacists Association, just briefly, so you know where we're coming from, the antimicrobial resistance, what we can do to tackle AMR, and then Commonwealth Partnerships for Antimicrobial Stewardship. I'll give you an introduction to that, and it'll be followed up with the details by the other 2 speakers. So first of all, who are we? The Commonwealth Pharmacists Association. We were established in 1969 and we're a registered charity and an accredited organisation of the Commonwealth. We represent over 1 million pharmacists through our members, who are the National Pharmacy Associations of the Commonwealth. And our mission is to empower pharmacists to improve health and well-being throughout the Commonwealth. We don't do this on our own. I know many of you may be from other healthcare professions as well. We work very closely with our colleagues, the doctors, nurses, social workers, dentists, and so on. And they all have their own accredited organisations with the Commonwealth as well. So we work through our strategic goals. So these are the 3 things that we focus on: workforce capability building, developing the pharmacy workthroughs and building capacity through education and training, health system strengthening, particularly supporting pharmacists to strengthen healthcare systems through the safe and effective use of medicines, prevention of disease and promotion of healthier lifestyles. And we also advocate for the profession, advocating for pharmacists to be embedded at all levels of medicines management, because we believe that they can enhance access and quality of medicines and pharmacy services because of the unique skill set that they provide. So our strategic goals run through all of our programs, and here's just a list of some of them. I've just grouped them into 3 categories here. So we've got programs around education, training and resources, we've got in-country programs, and we've got our advocacy programs. So you'll see here that in our in-country programs, we have 2 big AMR programs at the moment, and we're building this all the time. So we're now moving into also non-communicable diseases, but for the last few years we've really been focusing on antimicrobial resistance. We believe pharmacists have got a really unique role here. We're often seen as the gatekeepers of antimicrobials with our final port of call before a patient takes the medicine. So we've got that opportunity to educate patients, but also be able to kind of query prescriptions for prescribers and make sure that patients are getting the safest and most effective medication for them. So moving on, that's a bit about us. I don't want to dwell on that too much because I'm here to talk about antimicrobial resistance and our AMR program. So Many of you may already know this. I apologise if I'm starting from the beginning, but I think it's important that we're all on the same page. So where did all this come from? So the WHO released a report in April 2014 describing the growing threats that all countries face with antimicrobial resistance due to inappropriate use and lack of new antimicrobials in development. And you'll see here some quotes, both from the WHO Assistant Director General, describing a post-antibiotic era in which infections and minor injuries can kill. And it's far from being an apocalyptic fantasy. It's very real and a very real possibility in the 21st century. And then the quote here from Dame Sally Davis saying, we've reached a critical point, must act now on a global scale to slow this down. And as Julian mentioned at the high-level meeting earlier this year, this was really emphasised, and there was a great global consensus that we need to do more to tackle antimicrobial resistance. It is a real threat and it's here now. It's often called the silent pandemic. I don't know if any of you have heard that, but I think it's something that we all need to be aware of, and we all have a part to play in tackling this. So what are antimicrobials? I'm sorry if I'm kind of telling you the obvious, but I was told that there was a whole range of different people on this call, so just to make sure everybody knows what I'm talking about. So antimicrobials include antibiotics, antivirals, antifungals, and antiparasitics. So although when we talk about antimicrobial resistance, we often indirectly refer to this because we're talking about bacteria and antibiotics, but actually it covers all of these 4 different subsets. So what is antimicrobial resistance? Well, AMR is when a microorganism resists or overcomes the effects of an antimicrobial drug that originally was effective for the treatment or prevention of the infections that it causes. And the problem with this is that standard treatments become ineffective and the infection persists, increasing the risk of spread to others as well. So alternative treatments are limited, as we will see as we move on to this through this presentation. So I think that's something we really need to have in mind, that we can't just come up with another drug, because they often don't exist. So how does AMR occur? So AMR is a natural phenomena, but the presence of antimicrobials exert a selection pressure for microorganisms that possess resistant mechanisms. So it becomes a survival of the fittest for the bacteria. And this picture explains how AMR develops. At the start here, there's a number of microorganisms that can cause infection in diagram 1. When an antibiotic is taken, the antibiotic kills the bacteria causing the infection, but it also knocks out some of the body's good bacteria as well. So we have to bear in mind that all antibiotics and all medicines have side effects, and sometimes they aren't always beneficial. So microorganisms possessing genes to resist the antibiotic then remain, and they can multiply, causing a prolonged infection. So these resistant bacteria can then spread to other species, making other bacteria resistant as well. So that's in a nutshell how AMR occurs. Now, we often hear about One Health. I don't know if you've heard about this, but we do really need to think about tackling AMR from a One Health perspective, and this is why. So from this diagram, I think we can easily see how resistance can spread between humans, animals, and the environment. And that's when we talk about One Health, that's encapsulating all of those things. And at the top of this picture, you have cases of giving antimicrobials to animals and to humans. And in this case, the man in the picture is called George. It's the name of my son as well, but that's not why he's called George. This is I think it's from the CDC's diagram, so I've just borrowed it from there. So George takes an antibiotic and develops a drug-resistant bacteria in his gut. This may be transferred in a home setting to other members of the general community, or if George is admitted to healthcare or a nursing home facility, this may be spread to other patients or carers, either indirectly or directly, and the environment can become contaminated as well. On the other side of the diagram, you can see animals may also be given antibiotics, and again, selecting out resistant microorganisms, which can be passed on to humans from consuming meat that's not been correctly prepared, or passed into the environment in the form of fertilizer or water containing animal feces, which makes its way into crops to be consumed by other animals and humans. So what's the burden of AMR? Well, we know that in 2014, the UK Prime Minister commissioned the Jim O'Neill, who was an economist, to investigate the global impact of AMR. And this was really the first kind of big data that we got on this. And this AMR review concluded that if we don't undertake big policy initiatives, by 2050, there could be 10 million people around the world dying from AMR-related illnesses. And moreover, it was projected that the loss of economic potential due to AMR between 2015 and 2050 could be a staggering $100 trillion. So obviously there is a huge health impact here and threat to human and animal health, but also a massive economic threat to the globe. So more recently, the Graham paper was published in The Lancet. This was data from 2019, and this really broke down some of those figures into different disease states and the burdens that different countries and regions were facing. So this paper emphasised that this is all happening now, and it also called for urgent action. And it provides some sobering statistics, with AMR responsible for 1.27 million deaths worldwide and a further 4.95 million associated deaths. So we can see here that, you know, we are talking about a huge global burden and potentially causing more deaths than HIV, breast cancer and malaria. So further analysis of this data revealed that 1 in 5 who died due to AMR were children under the age of 5, which is also a staggering statistic and really emphasises that, you know, the vulnerable populations like young children, elderly, as often are the ones that bear the brunt of these burdens of disease. So lower respiratory tract infections accounted for more than 1.5 million deaths associated with resistance in 2019, making it the most burdensome infectious syndrome. So furthermore, the pathogens that you can see here, these 6 pathogens that you can see here were identified as claiming 73% of all lives lost due to AMR. So these are not new organisms. Those of you that are health practitioners will recognise them. They're commonly isolated in everyday practice, but they are increasingly resistant to the antibiotics that we have available. So what about the burden of disease across different regions? So AMR represents the largest threat to human health in sub-Saharan Africa and South Asia. And you can see here the estimates of 27.3 deaths per 100,000. But it's also important to note that no region gets away without the impact of AMR, and even regions such as Australasia, that has the lowest burden, still report 6.5 deaths per 100,000 due to resistant organisms. So this further breaks down the paper this further breaks down the data, and I'm sorry it's a bit of a busy slide, but there wasn't really any better way of showing this. So the high number of deaths from AMR here are really a symbol of the broader failures across the Sustainable Development Goals. So for example, the lack of access to clean water and sanitation allows AMR to spread rapidly in the community, and it's one of the drivers of the highest rates of resistant E. coli infections. And what is evident from this diagram is that no country or region is left untouched. And based on the estimates for 204 countries and territories, The Graham paper kind of really equips governments with the information that they need to show that, you know, action needs to be taken in every single country, in every single region, and there needs to be action taken to address this at the policy level as well as at the healthcare practitioner level. And as I said before, we've all got a role to play in this. So on the individual level, the consequences of AMR may mean that no effective treatment or prevention for an infection can lead to increase in morbidity and mortality. Routine surgeries may become too high risk, chemotherapy might not be possible, and treatment failure for common infections becomes more prevalent. So the impacts of unchecked AMR are wide-ranging and extremely costly. And when we think about the Sustainable Development Goals, it doesn't just affect the SDG 3, which is around good health and well-being, but it has wide-ranging consequences, also affecting food security, environmental well-being, and social economic development. So what can we do to tackle AMR? I hope you're all still with me. It's hard to tell when I can't see faces and we're on screens, but I hope you're following me. What can we do to tackle AMR? Well, isn't it simple? I can hear you say, if the drugs that we've got now don't work, don't we just make some different ones? Well, it's not quite that simple. And this is a diagram of the antibiotic pipeline, and it really is a sobering truth here. So we can see the different classes of antibiotics here. For those of you that are familiar with them, you'll obviously recognize these. But the sobering fact is that, you know, it's been 30 years since a new class of antibiotic was last introduced. And that's for various different reasons. There is a research going on to try to make new antibiotics. Perhaps that research is not as extensive as perhaps we need it to be, but there is very little in the pipeline. And the reality is, if new classes of drugs are discovered, they will be expensive. And the access in lower middle income countries, which is largely the countries we work with, is the access there is going to be limited and unaffordable, I would say. So we need to think about what we can do to preserve what we have got now and how we can act to make sure that we don't spread resistance and we try to reduce infections. So acting against AMR is a shared responsibility, as I've said previously in this talk, and everyone has got a part to play in helping to reduce the speed in which AMR develops and spreads. So the urgent need has really been redefined through the policy papers and through high-level meetings and the discussions that have been happening over the last few years. But really the solutions haven't changed. And there's 5 things here that I've listed that are effective intervention strategies to help tackle AMR. And depending on where we work and you know, what our sphere of influence is, there's something we can do in one of these 5 areas at least. So first of all, infection prevention control, that's IPC, for those of you not familiar with that term, remains a foundation for preventing infections broadly and is a real cornerstone in combating the spread of AMR. Number 2, preventing infections through vaccinations is really paramount for reducing the need for antibiotics. And there was a recent report in the Lancet which talked about, you know, what are the effective strategies in low middle income countries. And these top 2 interventions here were highlighted as probably the most effective in trying to tackle antimicrobial resistance, particularly in lower middle income countries. So number 3 here is reducing exposure to antibiotics unrelated to treating human disease. So reducing the use of antimicrobials in the environment and in food production. Number 4 is minimizing the use of antibiotics when they're not necessary. So obviously, if we're clinicians, being very responsible in terms of who we give antibiotics to, and as patients as well, you know, not putting pressure on prescribers to give antibiotics if perhaps you don't need them. And then number 5, maintaining investment in the development pipeline. And from the diagram that I showed earlier, I think it's obvious that, you know, we do need more research into antibiotics. And, you know, I think that there needs to be different models relating to that as well. At the moment, obviously the return on investment for drug companies making antibiotics is not great compared to a drug which you have to take every day. Antibiotics would be taken for a period of time, maybe a few days, and the numbers that drug companies would need to sell to recoup the costs of research and development kind of do not make it viable. So I think there needs to be different ways of investing in research as well. So I think that's very clear, hopefully, from the first part of my talk, that urgent action is needed to prevent antimicrobial resistance from sinking modern medicine. I'm just going to move on now and talk a bit about our Commonwealth Partnerships for Antimicrobial Stewardship programme and what this has got to do with AMR and what we've just talked about, really. So governments have responded to this crisis by ring-fencing international development and aid funding to support measures to tackle this global health threat. And the UK's Fleming Fund is one example of this. So Fleming Fund recognises the potential implications of AMR on global health security. As we said, those resistant bacteria can you know, transfer from patient to patient, from environment to environment. And as we've seen, you know, during the pandemic, microorganisms do not know geographical boundaries. This is not just an issue for, you know, lower middle income countries that have got the highest burden of disease. This is a global issue and one that needs a global solution. So Fleming Fund operates across human, animal and environmental health sectors using a One Health approach. And the programme is dedicated to tackling AMR in 25 lower middle income countries across Africa and Asia for enhanced laboratory capacity, surveillance and improving infection prevention control. And as you can see on the screen here, it's got 22 active country grants, 11 regional grants, and the data collected here, 155 countries have supplied data on the use of antimicrobial medicines in animals. And 170 national action plans have been developed with Fleming Fund support. So these national action plans are countries' kind of commitments to tackle AMR, to describe how they're going to do that. And this is something which Fleming Fund has supported countries to do. So how was CwPAMS born? Well, you might recognise one of those faces on here. I want to go back to 2018 and tell you a little bit about the birth of CwPAMS. So back in 2018, I had a meeting with the Commonwealth and the Fleming Fund to talk about this new fund that they'd created to tackle AMR and different aspects that we could possibly collaborate on. And Fleming Fund were very interested in pharmacists, being the gatekeepers of antimicrobials. As I said before, we're often the last person, the last healthcare profession a patient sees before being given or taking an antibiotic. And we have an important role and often an overlooked role, I think, in healthcare systems, especially in lower middle income countries. And we can really be that direct link between, you know, the patient and the prescriber in terms of labs as well. So we have a microbiologist working with us on the Fleming Fund projects. And she's very, very aware that there's a huge lack of microbiologists in Africa. And she's encouraging pharmacists to kind of be that link between the lab and the prescriber as well. So reviewing antibiotics based on, lab samples, sensitivities, and kind of reminding physicians to kind of change doses or IV to oral switches, or looking at reviewing medication where necessary. So we've got a huge kind of support from Fleming Fund in terms of the pharmacist role in antimicrobial stewardship, but obviously we work within a multidisciplinary team, and that's absolutely critical. So after I won over the Fleming Fund to say, look, I think we can do something with pharmacists, we can work with pharmacists in these low and middle income countries to help improve the use of antimicrobials. The pharmacists have got the knowledge, we need to kind of support them and kind of embed them in multidisciplinary teams, but also get the multidisciplinary teams on board and get the multidisciplinary teams focusing on the same goal in terms of rational use of antibiotics. So having worked overseas for many years, I'd seen too many programs come and go, and they made no difference whatsoever. I've seen experts come, teach us, practice didn't change. I've seen pharmacists and other practitioners go to other countries for a couple of weeks to learn something, they've come back, but there may be minimal changes, but actually the system element didn't change. So I knew that in order to implement my ideas in a way in which would have an impact, I needed to have a partner. So having met Ben from THET, probably about a year prior to these conversations, I was really taken by the health partnership approach. I think it's excellent. It's a tremendous way to bring people together behind a shared vision, but also the relationships that develop through those partnerships will carry the program much further than any kind of one-off training experience ever would. So I love what you do in health partnerships. I think it's fantastic, and I've got your old logo there because at the time obviously it was THET. So myself and Ben cooked up the Commonwealth Partnerships for Antimicrobial Stewardship with lots of help from obviously our teams. And we presented a concept to the Department of Health, and we've managed to get funding. And the rest is history, really. So what is CwPAMS? So CwPAMS is a health partnership programme between hospitals in Africa and the UK to tackle antimicrobial resistance with an emphasis on pharmacy leadership. The focus of the programme is around improving antimicrobial stewardship, including surveillance, building antimicrobial pharmacy expertise and capacity, enhancing infection prevention control, improving the use of clinical microbiology and antimicrobial prescribing data to inform clinical decisions, enhancing the detection and reporting of substandard and falsified antimicrobial medicines, which, if for those of you that don't know this, it's important when we talk about access to medicines, we think about the quality of those medicines, because it's estimated that up to 1 in 10 antimicrobials in low and middle income countries are either substandard or falsified. So we're getting poor quality medicines infiltrating the supply system, and that really compromises patient care. Sometimes those medicines can be toxic, but often they just do not give the result that we need, and it results in substandard dosing, and it further facilitates the development of antimicrobial resistance. So that's one element the programme does focus on. And the last element here is supporting community pharmacy, and by that we mean kind of investigating what community pharmacy can do in terms of helping to rationalise the use of antimicrobials, and how we can collect data around that to try and inform policy change. So CwPAMS 1 started in 2019 and that ran until 2022. We're currently on the second phase of the programme, which started in 2022 and is due to wrap up in 2025, although we've just got an extension hopefully to carry that on for a little bit longer. So currently we've got 24 partnerships across 8 African countries that you can see listed there. And we're excited to hear more about some of this from my colleagues following this presentation. So thank you for listening. I'm going to hand over now to my colleague Max to talk about some of the case studies around the Commonwealth Partnerships for Antimicrobial Stewardship Programme. So Max Nabiryo, or Maxencia as our full name is a public health practitioner with an extensive experience in managing and implementing health intervention programmes globally, fostering policy change to improve health outcomes. She's currently the head of programmes. She's had a promotion to that role last week. She works for us at the CPA, and she was previously the CwPAMS programme manager, coordinating the technical delivery of this multi-award winning programme across our 8 African, sub-Saharan African countries. So I'm going to hand over to Max, who's on video, for the next part of this lecture. Thank you.
Hello everyone, I'm really very excited to be presenting at this annual lecture today. My name is Maxencia Nabiryo, and I'm the head of programs at the Commonwealth Pharmacists Association, CPA. But prior to this position, I've been working for quite a while as the program manager on the CwPAMS program. And picking it from where my colleague has ended, for this session, I'll specifically focus on showing you some of the examples and microbial stewardship examples that we've developed through the program. To facilitate sharing of these examples and their usage, we do collect them into a repository that we call the CwPAMS Toolkit, as you can see on the right. And next, I'll be sharing to you more about the development of this toolkit. This toolkit is developed in a collaboratory manner. Us as the technical leads, the CPA, do work with colleagues from THET, or who are now called the Global Health Partnerships, GHP, and of course with central engagement of our health partnerships. The examples in this toolkit are evidence-based because prior to implementation of an intervention, our health partnerships must do a pre-MS assessments, and following implementation, they do a post-MS assessment. Some of the things showcased in here are strategies that have worked, case studies, tools and templates that our health partnerships have used and proven successful. But to guide or to facilitate and enable implementation of their interventions, we also co-develop with them other resources that are not in this toolkit, but they facilitate the implementation of the interventions that they do develop. And for the benefit of the audience today, I'll be alongside the case studies in this toolkit, also be highlighting some of the enabling special resources. And on the right, as we can see, are 7 core elements of a local antimicrobial stewardship program. When we're starting to develop this toolkit that continuously is being updated, we had international consensus and identified 7 core elements that can be important for implementation of an antimicrobial stewardship program in low and middle income countries where we do work. So our examples rotate around this, but like I said, this toolkit is a living document. We keep updating it based on global standards, global recommendations that do come through, but also new examples that we do receive from our network of health partnerships. And currently we're updating it aligned very closely within the 6 recommended WHO core elements. The good news is that all these fit in there well. So to first of the core elements where I'll be telling us some of the examples is senior hospital management leadership towards MS, a key aspect that must be considered to have a successful antimicrobial stewardship program. And some of the actions we do take as the CwPAMS project is to make sure we engage with the high-level staff at the hospitals where we do work, while starting this project, but also through the process and as we end it. Then we leverage existing structures like the drug and therapeutic committees in there, but also provide opportunities for developing future leaders, training MS leaders. And to do this, we have fellowships. We have a fellowship, one that is tailored to developing antimicrobial stewardship leadership of pharmacists in the African setting, and that we call the Africa Leadership Fellowship MS program. And then we have another fellowship that is focused on developing the leadership capacity of our colleagues based in the UK, the pharmacists in the UK, and that is called the Chief Pharmaceutical Officers Global Health Fellowship Program that we've run previously and look forward to future opportunities of running both programs in the future. And now to a case example in our existing toolkit from Zambia, for instance, following good leadership engagement, they have influenced creation of an antimicrobial stewardship pharmacist role. And this has come with benefits, including improvement in IPC, development of drug chart, development of guidelines for infection. And now to the other core aspect, which is accountability and responsibilities. What we've done here as actions is to develop different local policies and guidelines to guide antimicrobial use and IPC practices at the local facilities, established antimicrobial stewardship committees as governance structures, and also made sure that the projects being implemented do align well with the national action plans. And taking a case example from one of our health partnerships in Ghana, following need, they developed an antimicrobial stewardship policy. In it, there is expected standards for diagnosis, prescribing, essential trainings that can be given to staff, and also processes highlighting on how this policy should be used. And now the good news is to facilitate implementation of and usage of the policies. We have an amazing tool on the right, the Prescribing Companion app. So the Prescribing Companion app is a digital mobile app that can be on a phone or used on laptop website. And on this, we do upload standard treatment guidelines with approval from the national leaders, but also local guidelines that have been developed at the local sites. And whilst on this app, there is increase in usage because they are easily or more accessible compared to them being in a hard copy document. This app is available for download and you can access it via that QR code. Then to the education and training, which is a really very, very key aspect in running an antimicrobial stewardship program. What we've taken as actions from CwPAMS is to develop different training modules based on recommended standards, and have trained thousands of multidisciplinary healthcare teams in MS and IPC, but also gone an extra mile to do public and community engagement and create awareness on AMR, encourage good practices in IPC and also MS. And taking an example from Uganda, where I'm actually based, one of our health partnerships there have done training on MS, delivered it to over 200 healthcare workers there, inspired them following their training to sign up as antibiotic guardians, where they do take pledges to be good stewards, but also practice recommended practices, say in IPC. And our trainers have also been capacitated as those who can influence behavior change among the healthcare teams. And following the trainings, we do conduct feedback sessions to know how this has impacted and what we can do in the future to cause improvement. And to aid our education and training, we've developed several resources, and these include our Commonwealth Pharmacists Association CPD platform that, among other courses, does host a comprehensive package on AMR/AMS, and this has been made accessible to all our health partnerships and is actually free access to the rest of those who are interested in joining the Antimicrobial Stewardship package or training. And we've also developed another interesting tool, which is the Antimicrobial Stewardship game, which our health partnerships have enjoyed using whilst delivering their different education trainings, because it is a challenging game, but as you do play the game, you're actually learning and keeping excited. And the other is, among the many, of course, is the Antimicrobial Explainer videos, really a package or a series of videos talking about what AMR is, what are the recommended practices at the different points of care. And these have been developed with central engagement of our local teams to make sure the message is clear and understandable. And then, like I said, the toolkit is a living document, and as we talk, we are updating it with new lessons from our most recent projects, but also making sure it aligns very close with the WHO toolkit. And to access this toolkit and those other resources and many others that I've not been able to present here because of time, you may please scan the QR code there, and when updates come, you'll be able to see when we do upload them. And now over to an exciting practical example of one of our health partnerships from Malawi, and I hope you do enjoy that. Thank you.
Hi, everyone. My name is William Upute. I'm a pharmacist based in Malawi, and I'm a lead partner for the Malawi Wales Antimicrobial Stewardship project.
Hi, everyone. My name is Charlotte Makanga. I'm a pharmacist in North Wales, and I am the lead UK partner for the Malawi Wales Antimicrobial Pharmacy project. So our partnership is based throughout two very different countries, Malawi and Wales, and we have pharmacists and pharmacy technicians who are referred to as pharmacy professionals throughout both countries working on antimicrobial stewardship. So the pharmacists in Wales are based all over, and we all have antimicrobial stewardship roles in our jobs, and that's what we do. And our partnership was set up through the Pharmaceutical Society of Malawi and the Welsh Antimicrobial Pharmacist Group to work on antimicrobial stewardship activities and training, toolkits, and antimicrobial stewardship activities such as point prevalence studies throughout hospitals and health institutions in Malawi. We are based in 7 institutions throughout Malawi and then in 4 different health boards in Wales. So we cover quite a large area.
Thank you so much. So far we have done a lot. We have managed to set up AMS programs, starting with the 2 facilities, which we initially started with, being Cymru Central Hospital and Nzu Central Hospital. So these are tertiary hospitals according to the setup in Malawi. We have expanded to reach out to more hospitals in Malawi. Now we are in 7 facilities, as my colleague Charlotte said. So in the 7 facilities, 4 are tertiary hospitals and 3 are secondary care hospitals. This is very vital because for the majority of the secondary care hospitals, all of them, they do not have any antimicrobial stewardship program. So this project was like the first one that initiated that in these particular facilities. It was good to see facilities for the first time conducting a GPPS, thanks to our work as a partnership. On achievements, there has been too much to mention. But in summary, we have been able to train over 520 healthcare workers on antimicrobial stewardship across all these 7 facilities. We have been able to conduct GPPS that has been able to inform policy decisions and AMS action plans in these hospitals and also across the country as the data is shared with the nation level. This is in line with the National Action Plan for AMS for Malawi. We have also been able to support fellows. We have 5 fellows from our project in Malawi, and we had 3 from the UK. In addition, we have also been able to establish AMS committees based on the TORs that have been given by the National Coordinating Center. So in addition to that, we have had a good working relationship with the stakeholders, starting with the Ministry of Health and also the Fleming Fund grant in the country. So this has ensured collaboration and coordination. Last but not least, we have also had a training on leadership. This has been a mentorship program that is separate but funded by Housekeeping. This only targeted people that may not be actively involved in the partnership, but we targeted people that have the leadership potential, and we are able to do a leadership program as offered by the University of Washington. So in summary, we have done a lot, and we have published our work from CwPAMS 1.5, looking forward for more publications for others to live out what we have done. Thank you.
Our partnership is really strong. We're really lucky. We are one of the first pharmacy-only partnerships. We like to have we have a multidisciplinary working team. We have other professionals involved with us, but it's really great to work pharmacists and pharmacy technicians to other pharmacy professionals. I think we speak the same language regardless of where we are, and so that has made our partnership quite smooth and quite easy to navigate and work, because as pharmacists sometimes do talk a little bit of a different language, I think. There have been very few challenges. We've been able to visit both Malawi and Wales and had partnerships. Our teams come and visit both throughout the whole of Wales and throughout the whole of Malawi. We've travelled a lot in both of those countries to see how we work and share our way that we do things and share our knowledge and learning together. And as a result, I think that in the United Kingdom particularly, we've really benefited from that partnership. It's given us rejuvenation for work, and we've learned so many different ways of working and prioritization and understanding antimicrobial stewardship at a different level. And antimicrobial stewardship and antimicrobial resistance are global health issues, and unless we share that learning between countries and between health institutions, we'll never tackle it. So that's really key to the way that we work.
Thank you so much. Just to add to that, I think one of the challenges we had, barriers in distance initially were a problem, but thanks to the different technologies and to the fact that we have been able to visit one another continually, and also to get buy-in from management, it was a challenge initially because people were not used to this kind of working. But upon seeing the results and the benefits to the facilities and the country, we started getting the buy-in slowly and slowly. And now management teams have embraced us as a partnership and are willing to work with us. So I think Malawi has been one of the countries that has benefited a lot from this partnership, starting from the mentorship, starting from the sharing of resources, the technical expertise that the team from the UK brings to the table is priceless and very valuable. And also we have had an understanding of how things happen in the UK and also how best we can tailor-make that in our own setting, and we have been supported throughout the whole week of the partnership. So there's much we can say as the benefit, and some of the benefits will see the fruits in the coming years. But clearly, from the word go, we are able to develop things from the scratch because we had people that had been there before and they know what they were doing. So it has been very beneficial for us.
Yeah, and I can't underestimate really the same in Wales, how much we've benefited and how much we've gained in knowledge and experience learning from our colleagues in Malawi. It is a true partnership. And I really do think that pharmacy professionals working with pharmacy professionals really does benefit. From some lessons I would say to pass on: openness, develop a really good team. We're really lucky we used to meet weekly, we now meet fortnightly as a team. WhatsApp is a great friend and a great way, and we use Zoom a lot as well for all of our meetings. And we're just really open, clear. We set quite clear, defined goals. William's leadership has been exceptional from the Malawi side to gather everyone and bring everyone together, and the buy-in from the two big groups of the Pharmaceutical Society of Malawi and the Welsh Antimicrobial Pharmacy Group. And in Wales, we went a step further and we got the buy-in of all the chief pharmacists in Wales as well to make sure that the volunteering time was allowed and that we could go forward and do things with their support as well. And we feed back regularly to the Welsh chief pharmacist group, and they've been a really good key leadership team for us to influence, to allow our colleagues in Wales to have the time to volunteer and do this partnership working.
Thank you so much, Charlotte. To add to that, I think just to echo what she has said, to say that openness is very important, and also it's important to make some things, to formalize some of the things, especially we had an MOU that we signed, because that helps everyone else to understand their laws, every partner to understand their laws. And teamwork is very important. Like for me, there have been times where I couldn't do something, but Charlotte, I know Charlotte has my back. I know that I can count on some members of the team so that they can be able to push things forward. So I think that brings the togetherness, and also it helps the partnership to achieve the common goals and to do the greater good. So I think, and also to continually learn. Both of us have continually improved from where we started to where we are today. We have been mentored by people that understand the partnerships better. So continually improve, because there are always new things that are coming that you may not be able to know on your own, but you have to involve other people as well.
Yes, thank you very much, William. Thank you.
Thank you so much.
Right, thank you very much. We're running rapidly out of time, actually, and we've got a bit of a hard stop at 3 o'clock. So there is one question that's come through on the Q&A, and I'm not sure we've really got time to answer that, about agriculture and antimicrobial resistance. Victoria's got to leave at 3, so I think really I ought to bring this section to a close and hand over to Julia. But before I do that, just to thank Victoria very much for putting together such a good program. Thanks to her colleague Max in Uganda and William in Malawi, and obviously Charlotte in Wales. And that's partnership is a good place for lots of people in Wales to think about getting engaged in the AMR, AMS work going forward. And I'm delighted to see such a nice link up between, a Commonwealth initiative working in sub-Saharan Africa and having a link to Wales. So that's fantastic. So I'll hand over now to Julia to bring the meeting to a close. So thank you very much to all our speakers.
Thank you, Tony, and thank you everybody so much for your time and expertise and contributions. Today is Universal Health Coverage Day. Global Health Partnerships are launching a report in Parliament, and I've just pasted a link into the chat and just will ask Cymru Africa colleagues to make sure that's available to everybody so you can immediately download and have a look. There are a number of sections about the Commonwealth Partnerships programme, particularly around antimicrobial stewardship and the absolute importance of health partnerships. So just want to thank everybody for their time today. This will be available to colleagues, so feel free to pass this round as it comes out. And just really want to make sure that we're aware that there are many toolkits with which we can engage, with which we can encourage each other and partners and potential partners. And these are things to think about going forwards as we want to improve global health together. Thank you very much for joining us.